So we have one mast cell stabilizer that it can be taken orally or topically, like via nose spray, and they block the release of histamine. This is one that you're going to use prophylactically. So it's not with the onset of an allergic reaction. You're going to use it before you have an allergic reaction. So this is used for people who have chronic allergies. And cromolyn sodium is that mast cell stabilizer that you can take orally. There are a handful of ophthalmic mast cell stabilizers, and here you can see them over here. Again, cromolyn, pretty similar to your cromolyn sodium, just taken for an ophthalmic solution. And then the rest of these. These are prescription only, and we're not 100% sure how they work. So we don't know the exact mechanism of action, but we know it stops the release. Again, prophylactically for chronic allergies. Side effects are pretty minimal, stuff like wheezing, nasal itching, or burning with the topical. And this really, our antihistamines, mast cell stabilizers, link in really closely with respiratory pharmacology, because a lot of respiratory pharmacology is going to deal with allergies or bronchial constriction, that kind of stuff, because basically your respiratory system is just a series of tubes starting at your nose and mouth, going down your trachea, and then branching into smaller tubes until you get down to your alveoli. This is stuff that I hope you picked up in physiology or maybe even anatomy about the alveoli, and then your type 1, type 2 alveolar cells, dust cells, that kind of stuff. But basically, you have to get the air down here to the alveoli, and then it's going to diffuse across into the capillaries where the oxygen is picked up by the red blood cells, and the blood cells are going to give off the carbon dioxide, all because of concentration gradients, diffusion, that kind of stuff. Right here is something that's pretty important, especially when we're talking about COPD, chronic obstructive pulmonary disease. And it's called the mucociliary escalator. And what it is, you have these pseudostratified columnar cells that have cilia, these little bitty hairs, right? And what they do is they all beat in unison. And they kind of make me think of people rowing a boat, right? It's like stroke, stroke. And they're pushing this layer of mucus that is going to trap like dirt particles, pathogens in it. And they push it from the alveoli up the trachea to the pharynx, where you can either spit it out as a loogie or swallow it, right? And so this mucociliary escalator is really important in the movement of the mucus and keeping your airways clean and clear. So COPD, one of the most common diseases we see in America, and it kind of comes in two forms. It can either be due to chronic bronchitis or emphysema. And it doesn't matter if it's chronic bronchitis or emphysema, smoking is typically the main reason for either of these. Either that, or you have been exposed to environmental toxins for a long time that mess with your respiratory lining, like coal dust and stuff like that. So with chronic bronchitis, it is chronic irritation of the bronchioles, right, of that respiratory tract. And with that chronic irritation, it's going to cause them to make this thicker mucus to try to prevent that irritation. It's also going to change the lining of your bronchioles. Something we see is with chronic irritation, they can go from pseudostratified to stratified squamous, because that is more protective. You also damage the mucociliary escalator. You lose cilia. Smoking, tobacco, nicotine actually paralyzes the cilia and so they can't beat in unison anymore, and so you're not effectively moving that mucus throughout your lungs. Something that you see with chronic bronchitis is a productive cough. So each time you cough, you do get mucus sputum coming up. You also have difficulty breathing and increased respiratory infections because your mucociliary escalator is not working, right? With emphysema, this is where you have the destruction of the alveoli. So these alveoli, you go from having these tiny sacs to bigger sacs because the walls between them get broken up. That gives you less surface area for diffusion, which means you're not getting as much oxygen. And also with that destruction, you are taking elastic tissue and replacing it with collagen. And so you don't get that bounce back. So when you breathe in, your lungs expand and they get stretched. And then when you breathe out, you have this elasticity that pushes out a lot of the air. And so with that decreased elasticity, it makes it a lot harder to breathe out. You really have to to breathe out. You have to push. You have to use your abdominal muscles to really push on the lungs and use the diaphragm to push on the lungs to force out that air due to that decreased elasticity. And then we have asthma. So asthma comes with your bronchoconstriction, can lead to shortness of breath, wheezing, makes you feel like you're dying. And so you can get panic on top of that, which works on your sympathetic autonomic nervous system and a lot of different stuff. So asthma, it's an inflammatory disease. It is your body thinking it is attacking a bad guy and setting off this inflammatory reaction, which can lead to the constriction of the bronchioles. And like we talked about last time, you get hives, itchy, watery eyes, all kinds of stuff. And it's hyper-responsive. So it's not supposed to be that strong of a reaction, right? And it can be all kinds of environmental factors, like cold air can cause asthma, right? Or dust, pollen, whatever. You get mucosal edema, so you get buildup of mucosa, lots of mucus building up. The mucosal cells have a lot of fluid in them to produce the extra mucus, and you also have decreased ciliary action, so they're not beating as well. There's a lot of chemical mediators to this, a lot of those ones that we talked about last time, like histamine, your eosinophilic chemotactic factor of anaphylaxis. It's not one that we talked about, but we did talk about eosinophil activators, and this falls into that category. Plus your prostaglandins and your leukotriene. The body's going to release histamine anytime it gets injured or insulted, right? Anytime your mast cells think they found a bad guy, they're going to release histamine, which is going to cause bronchoconstriction, vasodilation, increased vascular permeability, which means you can get extra fluid out there with those blood cells, those white blood cells, so they can attack whatever the bad guy is, right? Histamine actually isn't the most important part in asthma. So it does do some bronchoconstriction, but for a lot of asthmatics, you don't see them taking antihistamines. And we'll talk about like different drugs that you should take if you have asthma. Typically not antihistamines. With your eosinophilic chemotaxic factor of anaphylaxis, ECFA, these get released from eosinophils and your mast cells to attract eosinophils to an injury area. The eosinophils are also part of general inflammatory processes and allergic reactions. And then your prostaglandins and leukotrienes. Both of these come from arachidonic acid. We've talked about prostaglandins before, and if you remember the little chart, it's like you have arachidonic acid, you come down, and then it splits into prostaglandins and leukotrienes because they use different enzymes. With prostaglandins, if you remember, they use cyclooxygenase, right? COX-1 or 2. With your leukotrienes, they actually use a lipase, and it's called lipooxygenase, and that makes your leukotrienes. both of them, either way, they're going to cause bronchoconstriction, edema, mucus production. And it's phospholipase A that cleaves that arachidonic acid from the cell membrane, right? And so it's going to release the arachidonic acid that then can make prostaglandins or leukotrienes, depending if you have lipooxygenase or cyclooxygenase. And here you can kind of see that process. So here's your cell membrane. Phospholipase A comes in and cleaves it off. And here is where your corticosteroids, like cortisol, can come in. Any of your steroidal anti-inflammatory drugs work right here. That stops the production of arachidonic acid. And then either lipooxygenase or cyclooxygenase. Cyclo is going to make your prostaglandins. Lipo is going to make your leukotrienes. And then you can have drugs that are anti-leukotrienes that block the receptor. Your NSAIDs, aspirin, ibuprofen, block the production of your prostaglandins. You can go from there. So one thing we use to treat COPD and asthma are bronchodilators. And we'll pick up going over these drugs in the next section.